Dear EDIC aspirants, as the EDIC Part 1 exam is nearing, just a quick snapshot of important questions.
Question 1. A 64-year-old man with septic shock, MAP 52 millimeters of mercury despite fluids, norepinephrine 0.6 microgram per kg per minute, develops new-onset atrial fibrillation with rapid ventricular response, heart rate 155 bpm. Lactate is 5.2 millimole per liter, CVP 12 millimeters of mercury, echocardiography shows preserved LV systolic function but borderline RV function. Which is the most appropriate therapeutic adjustment? Continue norepinephrine and start amiodarone infusion. B. Add vasopressin infusion and reduce norepinephrine dose. C. Switch norepinephrine to dopamine infusion. D. Initiate phenylephrine infusion and stop norepinephrine. E. Add dobutamine infusion for inotropic support. Correct answer is B. Add vasopressin infusion and reduce norepinephrine dose. Explanation. High-dose norepinephrine may predispose to arrhythmias as this patient has atrial fibrillation. Vasopressin, non-adrenergic mechanism, is guideline recommended as an adjunct in catecholamine refractory septic shock. This patient is in shock. Amiodarone may control AF but does not address vasopressor optimization. Dopamine has higher arrhythmogenic potential. Phenylephrine may worsen RV dysfunction due to pure alpha-agonism. Dobutamine is indicated if there is myocardial depression, which is absent here. Question 2. A 58-year-old woman with septic shock and oliguric AKI is on continuous venovenous hemodiafiltration, CVHDF, with an effluent dose of 25 ml per kg per hour. She is receiving vancomycin for MRSA pneumonia, current trough 6 mg per liter, target 15 to 20 mg per liter. Her hemodynamics remain unstable on norepinephrine. What is the best next therapeutic adjustment? Increase vancomycin dose and continue same CRT prescription. B. Increase CRT dose to 35 milliliters per kilogram per hour for enhanced clearance. C. Reduce CRT dose to 20 milliliters per kilogram per hour and increase vancomycin dose. D. Switch to intermittent hemodialysis for higher clearance. Add gentamicin to broaden coverage. Correct answer is A. Increase vancomycin dose and continue same CRT prescription. Explanation. Current CRRT dose, 25 milliliters per kilogram per hour, is adequate. Higher doses do not improve outcomes but increase risk of drug clearance. Subtherapeutic vancomycin is likely due to increased clearance on CRT plus sepsis volume of distribution. Increasing CRT would worsen drug clearance further, reducing CRT risks under dialysis. IDSA recommends adjusting vancomycin dosing rather than changing CRRT settings for subtherapeutic levels. Question 3. A 44-year-old patient with severe ARDS due to influenza, partial pressure of oxygen to FiO2 equals 70 millimeters of mercury on PEEP 15 centimeter of water, FiO2 0.8, VT 6 milliliters per kilogram predicted body weight, is deeply sedated but desynchronous with the ventilator. Plateau pressure is 31 centimeter of water, driving pressure 16 centimeter of water. Which therapeutic intervention is most evidence-based at this stage? Start continuous cisatracurium infusion for 48 hours. B. Increase PEEP to 20 centimeter of water and maintain same sedation. C. Switch to high-frequency oscillatory ventilation. D. Initiate inhaled nitric oxide for rescue oxygenation. Increase tidal volume to 8 milliliters per kilogram predicted body weight to improve synchrony. Correct answer is A. Start continuous cisatracurium infusion for 48 hours. Explanation. The Accuracies trial showed benefit of early short-term neuromuscular blockade in severe ARDS. Current recommendations do not support the routine use of neuromuscular blocking agents in ARDS patients, especially with lighter sedation, as evidence does not show a mortality benefit. However, these agents may be considered for short durations, up to 48 hours, in selected cases of moderate to severe ARDS who require deep sedation to facilitate lung protective ventilation or prone positioning. Increasing PEEP may worsen overdistension given high plateau pressure. HFOV did not show survival benefit in recent trials. Inhaled NO is only a temporary rescue therapy. Increasing tidal volume worsens VILI, ventilator-induced lung injury. Question 4. A 36-year-old man with traumatic brain injury develops generalized convulsive status epilepticus refractory to intravenous lorazepam and phenytoin. He is mechanically ventilated, ICP 20 mm of mercury, MAP 75 mm of mercury. Which is the most appropriate next-line therapeutic option? Start intravenous levetiracetam infusion and continue phenytoin. B. Initiate continuous intravenous midazolam infusion. C. Start intravenous propofol infusion titrated to EEG burst suppression. Administer intravenous sodium valproate bolus followed by infusion. Initiate thiopental coma titrated to burst suppression. Correct answer is B. Initiate continuous intravenous midazolam infusion. Explanation. After benzodiazepine and phenytoin failure, patient has refractory status epilepticus. Status epilepticus is considered refractory when seizures persist despite prompt administration of a first-line benzodiazepine and at least one second-line intravenous antiepileptic drug. Recommended options: continuous anesthetic infusions, midazolam, propofol, barbiturates. Midazolam is preferred as initial choice due to lower risk of hypotension versus propofol or thiopental. Valproate or levetiracetam are alternative adjuncts but not primary rescue at this stage. Question 5. A 72-year-old woman with hypothermia, 33 degrees Celsius, bradycardia, HR 42 per minute, hypotension, hyponatremia, sodium 124 millimoles per liter, and altered mental status is admitted to ICU. TSH is markedly elevated, free T4 undetectable. Which is the most appropriate immediate therapeutic regimen? Intravenous levothyroxine 200 to 400 microgram bolus, then 50 to 100 microgram per day plus intravenous hydrocortisone. B. Intravenous liothyronine 25 microgram bolus, then 10 microgram every 8 hours without steroids. C. Oral levothyroxine via NG tube 75 microgram daily plus supportive care. D. High-dose intravenous levothyroxine, greater than 500 microgram, without steroids. Intravenous hydrocortisone only, followed by delayed thyroid hormone replacement. Correct answer is A. Intravenous levothyroxine 200 to 400 microgram bolus, then 50 to 100 microgram per day plus intravenous hydrocortisone. Explanation. Myxedema coma requires rapid thyroid hormone replacement plus empiric steroids until adrenal insufficiency is excluded. Levothyroxine is the preferred preparation. Liothyronine may be added but carries higher arrhythmia risk. Oral absorption is unreliable in critical illness. Excessive initial doses of more than 500 microgram risk arrhythmias. Steroids are essential due to risk of precipitating adrenal crisis.
Dear doctors, I hope these questions were useful to you. If you have any feedback, suggestions, or comments, or if you want to discuss any question or answer, please write down in comment section where I will respond.